Endometrial cancer is the sixth most common cancer worldwide in females, and it is the 14th most common cancer overall. Globocon 2020 tells that there are 4,17,000 new cases, while 97,000 deaths occurred in 2020 due to endometrial cancer. In India, 16,000 new cases and 6,000 deaths have been also reported. Now, what is the most common symptom of endometrial cancer? The most common symptom is postmenopausal bleeding, and in postmenopausal bleeding, there are 90% cases which are benign, while the rest 10% cases there is possibility of endometrial cancer, and hence it warrants endometrial biopsy and sampling. The mean age of onset of endometrial cancer is 63 years, while the ranges from 55 to 70 years. 25% cases can be premenopausal females, that is less than 40 years age group, and this warrants fertility sparing surgery in them. At diagnosis, most of the cases, around 75%, are confined to the uterus because of the symptom postmenopausal bleeding. It is possible to detect the endometrial cancer at an early stage, and 10 to 15% cases can be extrauterine or higher stage, and more than 50% of all uterine cancer related death occurs in extrauterine diseases. Now, coming to the risk factor, what are the risk factors for endometrial cancer? Age, most commonly more than 55 year of age, early menopause, early menarche and late menopause. Unopposed estrogen exposure has 1.5 to 4 times higher risk. Parity, high parity is protective, pregnancy is protective, abortion is protective, pills also protective, and after OCP use of 3 years, there is 80% reduced risk of endometrial cancer after 10 years of use, and protection lasts for 20 years after stopping. PCOS, which is due to chronic anovulation, and there is unopposed estrogen exposure, so this can also predispose a patient to endometrial cancer 2.7 times. HRT is also associated with endometrial cancer. Tamoxifen use, because tamoxifen is agonistic on uterus, and if there is genetic syndromes like BRCA1 and granulosa cell tumor of the ovary, which is an estrogen secreting tumor. So, along with BRCA syndrome, mainly BRCA1, there is also association of Lynch syndrome, also known as HNPCC or hereditary non-polyposis coli syndrome. In 3% of the cases of endometrial cancers are hereditary, and this HNPCC can have colorectal cancers in 60 to 80% of the cases, endometrial cancer in 40 to 60% of the cases, ovarian cancer in 10 to 12%, small bowel cancers, renal pelvis cancer, and ureter. Obesity causes anovulatory cycles, and there is peripheral conversion of androgen to estrogen, which creates a highly estrogenic state and can predispose the patient to endometrial cancer. Metabolic syndromes like obesity, diabetes, hypertension, dyslipidemia leading to endometrial proliferation, and this is also associated with a higher risk of endometrial cancer. So these are the causes of endometrial cancer in premenopausal and postmenopausal age group. For staging, we use the FIGO 2023 FIGO staging system, and we have already discussed it and we are revising it now. What happens in stage 1? The disease is confined to the uterus or the ovary. It is further divided into 3 parts: first A, first B, and first C. Everything that comes under C is aggressive, and first A and first B are non-aggressive tumors. So if the endometrial disease is confined to the endometrium, it is low grade, or if there is polyp with less than 50% involvement of the myometrium and there is no LVSI, then it is stage 1A. And if the endometrium is involved more than 50%, then it is stage 1B. And if the disease is aggressive, it is 1C. Now, this stage 1A is further divided into 3 parts. That is 1A1, where there is endometrial polyp and or involvement of the endometrium. 1A2, where the disease is less than 50% without LVSI. And if there is ovarian involvement, then this is stage 1A3. Stage 2, when the disease is limited to uterine corpus and the ovarian side, and it is further divided into 3 parts: 1A, 1B. Both are non-aggressive histological types, while 1C is aggressive here also. And in stage 1, we have discussed this. Yes, this is stage 1 only. Happens in stage 2. Stage 2 is when the disease is limited to cervical stroma with there is presence of LVSI, but this is substantial LVSI, minimal LVSI, and aggressive histological types with myometrial invasion. So this is divided again into 3 parts: 2A, 2B, and 2C. 2A, 2B are non-aggressive, and if there is substantial LVSI, this is stage 2B, and if the disease is aggressive with myometrial invasion, this is stage 2C. Stage 3 is any histological type, whether either low grade or high grade, and if there is local or regional spread in stage 3A, serosa or adnexa is involved, and in stage 3A1, ovary or fallopian tube involvement, and if serosa and uterine adnexa is involved, then stage 2A2, and if there is involvement of vagina, parametrium and pelvic peritoneum, then this is stage 3B, and if vagina and perimetrium is involved, then stage 3B1, and if pelvic peritoneum is involved, then stage 3B2. Stage 3C1 involves pelvis with involvement of, if there is microscopic involvement, then this is stage 3-1C ka first part, and if there is microscopic involvement, then this is 3C1 second part, and in stage 3C2 there is involvement of para-aortic lymph nodes. So in 3C1 pelvic lymph nodes are involved, and para-aortic lymph nodes are involved in stage 3C2. Now coming to the last stage is when there is involvement of bowel, bladder and distant mets are also there. So if there is involvement of bowel and bladder only, then this is stage 4A. If abdominal peritoneal metastases are present, then this is stage 4B, and if distant metastases like lung, liver, brain and bone are involved, then this is stage 4C. And what is stage 1A ampole? So this is stage 1A where there is involvement of endometrium, and the involvement is with non-aggressive histological types, usually low grade, and myometal invasion is less than 50%. Ampole means the molecular classification includes the pole mutated, which is associated with a good prognosis. The most important prognostic factor for cancer endometrium is, can anybody tell me? Yes, lymph node metastasis. So, based on the classification system, endometrial cancer can be divided into endometrioid type and non-endometrioid type. Endometrioid is the most common, and it is seen in 70 to 80% of the cases, associated with good prognosis. It could be adenocarcinoma variants, grade 1, grade 2, grade 3. If less than 50% solid component is there, then this is grade 1. If 5 to 50% of the solid component is there, then grade 2. And if the solid component is more than 50%, then this is grade 3. Non-endometrioid carcinoma includes clear cell and differentiated non-neuroendocrine mixed and uterine carcinosarcoma, while the serous adenocarcinoma is around 10%, and immunohistological marker is p53. If p53 diffusely positive, then it will take up the p53 stain, and p53 null pattern can also be seen where there is no nuclear staining. Now coming to clear cell carcinoma, which is seen in 5% of the cancer and associated with poor prognosis. This is associated with NAPS and A positivity, and there is clearing of cytoplasm also. The another classification system other than this histological classification is Bachmann classification, in which we divide the endometrial cancer into two types, that is type 1 and type 2. Type 1 is a low grade endometrial cancer. It is seen in younger obese females, and because there is presence of obesity, so the androgens are getting converted to estrogen, and there is hyperestrogenic environment. So this is estrogen related, and the grade is grade 1 or grade 2, and because of the presence of estrogen, we can give drugs which can prevent this hyperestrogenic environment, and hence it is detectable in early stage, and the prognosis is favorable. The common mutation that can be seen in type 1 endometrioid cancer is P10 or KRAS mutation, while type 2 is higher grade. It is seen in elderly thin women, and there is mutation of PTP53. There is no hormone dependence, and they are usually seen in postmenopausal females. The association can be grade 3 endometrioid, clear cell papillary and carcinosarcoma. The spread is early, detection is late, and it is usually associated with worst prognosis. Now coming to the third classification system, that is molecular classification, in which we divide the cancer into three parts or based on the test. First one is pole mutated. Pole is DNA polymerase E mutation, which is detected by next generation sequencing and associated with good prognosis, while mismatch repair gene or MMR gene deficiency. The common gene involved are MLH1, MLH2 and MSH6, and this is associated with HNPCC syndrome. And the another gene is PMS2. We detect both these p53 abnormality and IHC through IHC. p53 abnormality is the third test that we performed in molecular classification. Now these molecular types can be pole mutant, MMR deficient or p53 abnormal, and if there is none of them is present, then we classify it as NSMP, which is non-specific molecular profile. Molecular trial done by Cancer Genome Atlas denoted a Kaplan-Meier curve in which pole mutation has the best prognosis, p53 worst prognosis, while MMRD is intermediate prognosis. And this PROMISE trial also suggests that p53 is associated with the worst prognosis. Now, based on the molecular risk stratification, we can classify the patient as low risk, intermediate risk, high intermediate risk, and high risk, and it includes staging and histology. Low risk patients are the stage 1 endometrioid variety, low grade, grade 1, grade 2, LVSI negative or focal like stage 1. Then if stage 1A endometrioid high grade means is grade 3. LVSI does not depend whether positive or negative. If positive, then it should be focal. 1B endometrioid low grade stage 1A non-endometrioid cancers without myometal invasion are included in intermediate group. High intermediate group includes stage 1 endometrioid with substantial LVSI and stage 1B endometrioid high grade regardless of the LVSI status, and stage 2. Now, high risk patient include stage 3 to stage 4A with no residual disease, and if there is residual disease, then this is advanced metastatic disease. And if there is non-endometrioid with myometal invasion and no residual disease, then high risk in stage 4B is always included in advanced stage. Then adjuvant treatment in low risk patient, there is no role of adjuvant therapy, only TH and BSO is sufficient. And intermediate risk needs Walt brachytherapy also. High intermediate risk, we give slightly more radiotherapy like ABRT or external beam radiotherapy, and in high risk cases we give radio and chemotherapy, and palliative therapy is given in advanced metastatic disease. So how will you proceed with the molecular profile? So first of all, you have to do a test known as mismatch test, then mismatch test. If this mismatch test is positive, then or low protein expression means MMR IHC abnormal, and if this is normal, then we have to do polymerase sequencing based on next generation sequencing. If it is mutated, then this is pol E mutated, and if it is wild type, then we have to do P53. If P53 aberrant expression is seen on immunohistochemistry, then P53 abnormality, which is associated with worst prognosis. Or if there is wild type IHC of P53, then NSMP or non-specific molecular profile. So first mismatch, then pol, then P53, and then NSMP diagnosis is made. Now, what are the prognostic factors for endometrial cancer? Lymph node metastasis, as we already know that it is the most important risk factor. Other factors can include the age of the patient. More the age, poor the prognosis. Better the histological type, poor the prognosis. Higher the grade, poor the prognosis. Stage 3, 1B, 30% lymph node metastasis is seen, while in stage 1A, low grade, only 3% lymph node involvement is seen. LVSI is also an important factor for recurrence lymph node metastasis, distant mets and parametrium involvement. Cervical stroma involvement is also important for deciding the prognosis as well as the management. Peritoneal cytology, ERPR positivity, tumor size. If small tumor means less than 2 cm, then 5% chances of lymph nodes metastasis, and more than 2 cm tumors can have 15% chances of lymph node metastasis. And then we have to do a very important risk stratification based on the molecular classification. Now we will, if the patient of postmenopausal bleeding comes to us, or if there is possibility of hereditary cancer syndrome, we have to do a pelvic general examination of the patient. And if on USG examination the ET is increased, or there is postmenopausal bleeding which is persisting, and if the USG is showing heterogeneous endometrium, or the patient is having bleeding despite unidentifiable endometrium, then we have to do a biopsy. This can be pupil biopsy, dilatation curettage, hysteroscopic guided biopsy, or DNC sample. So so based on that, if the endometrial biopsy is abnormal, then we have to do a higher investigation to assess for the lymph node involvement or the chances of metastasis. Then we have to do an MRI pelvis, and metastatic workup is given. And if if it is early stage tumor, then we can do surgeries. And late stages like stage 4, we have to plan the patient for chemo and radiotherapy, and surgery is not done in those cases. So for debulking surgery, we have to perform a pre-anesthetic checkup, and performance status of the patient is known. Now, what is pupil biopsy? Pupil is a thin suction catheter which is inserted pervaginally into the endometrial cavity, and through suction we take the endometrial sample. Pupil biopsy is an OPD procedure. It is preferred, and accuracy is 99%. No role of frozen section as to assess the myometrial invasion, because myometrial invasion is not studied in pupil biopsy. Histological tumor type and the grade of endometrial biopsy is required, and it will detect, this endometrial biopsy can detect the histological grade as well as the histological type. So after doing this, we can use the TVS to assess the uterine factor. MRI pelvis and abdomen can be done. MRI superior to CT in ovarian cancer as well as the endometrial cancer. And if there is a possibility of metastasis, then CT, chest, abdomen and pelvis can be done. And there is no role of PET CT in primary staging. Now what is the treatment? Treatment is total hysterectomy plus bilateral salpingo-oophorectomy and lymph node staging. Ovarian preservation can be done if the female is less than 45 years with no family history of Lynch syndrome and BRCA mutation. In omentectomy is suggested only for high risk cases. Lymph node debulking can be done. It can be done as a sequential lymph node systemic lymphadenectomy, or there can be sentinel lymph node biopsy also. The role of minimally invasive surgeries is preferred over open surgeries, and this could be done through laparoscopic surgeries like laparoscopic assisted vaginal hysterectomy and total laparoscopic hysterectomy, robotic assisted surgeries. And there is reduced hospital stay, blood loss and post-op pain associated with minimally invasive surgery. There are two trials, GOG Lap2 trials, which is gyno-oncological group, laparoscopy trial or LACE trial, which is laparoscopic approach to cancer endometrium, and this suggests that there is equal outcome with minimally invasive surgery and open surgeries, while there is reduced hospital stay, blood loss and post-op pain associated with minimally invasive surgeries, and hence minimally invasive surgeries can be performed in patients of cancer endometrium. So how will you do this sentinel lymph node biopsy? Sentinel lymph node is the first node that drains into the tumor, and if it is positive, then this is stage 3 C1 disease. We already have discussed this. An entire nodal base till renal nodes is removed. Then we have to use the indocyanine green as a preferred method, and we have to inject this dye at 3 o'clock and 9 o'clock position, because at this location cervical arteries are present, and green coloring indicates the mapping. Re-injection may be tried, and H&E staining can be done. If the macromets means more than 2 mm are present, this is also known as macromets, and if the metastasis or disease focus is less than 2 mm, this is micrometastasis, and appearance of green color indicates that the nodes are termed as mapped. So what will you do in low risk endometrial cancer? In low risk endometrial cancer, where there is low grade tumor, the myometrial invasion is less than 50%, non-aggressive histological type, stage 1 disease, we can do TH and BSO, and there is no need of adjuvant treatment for low risk patients. While in intermediate patients, we already have discussed this, vaginal brachytherapy can be needed. In high risk cases, we can do EBRT along with BBT, and in high risk cases, sequential chemotherapy, radiotherapy is recommended. Now coming to follow up for high risk patient and low risk patient, the follow up is different. For high risk patient, initially for 2 years they have to come every 3 monthly, followed by 6 monthly for next 5 years, and then annually. While in low risk cases, initial 2 years they need 6 months follow up, and then annually. Now for screening, we have to routine screening is not recommended, but if the patient is having history of Lynch syndrome in the family or MMR deficiency testing is positive, then endometrial sampling is performed annually from 35 years of age. And if the family is complete, then we have to advise them for total abdominal hysterectomy and bilateral salpingo-oophorectomy. Now coming to fertility sparing surgeries, if the female age is less than 45 years or she has not conceived yet, then hormonal therapy can be tried without hysterectomy in these females. And the criteria, as the age should be less than 40 years, there is presence of type 1 tumor, which is a endometrioid variety, only uterine involvement is seen, and there is no evidence of myometrial involvement in MRI, and there is no family history. So we can start them on progesterone and high dose progesterone like Gestrol 160 to 320 milligrams per day, or medroxyprogesterone acetate 400 to 600 milligrams per day can be advised, along with LNG IUCD for 6 to 12 months. Then we have to start them on strict surveillance, 3 monthly TVS and endometrial biopsy to be done to exclude progressive disease. And when the family is complete, then TAH can be done, and if conservative treatment fails with progesterone, then directly we have to do TAH and BSO in these patients. Now what will you do if there is presence of recurrence on follow up? So this recurrence can be proved by imaging or the biopsy, and they are divided into two groups, as we have already discussed. If they are treated previously with surgery, then this time we have to treat them with radiotherapy, and if previously radiotherapy was given, then this time we can try surgery in them. So radiotherapy pre-treated and radiotherapy naive. The site of recurrence can be loco-regional, like there is recurrence in the vault or the pelvic area. Nodal, like lymph nodes like pelvic and para-aortic lymph node involvement is seen, or lung, liver and peritoneum involvement seen. So if there is isolated vaginal recurrence, means loco-regional recurrence is there and previously radiotherapy was not given, then radical radiotherapy can be given, and if radiotherapy pre-treated, then surgery and pelvic excision surgeries can be performed. If there is nodal involvement, the surgical resection of node is recommended, and if it is oligometastatic, that is metastasis is less than 5, then stereotactic body radiotherapy or surgery along with CT can be performed. Multi-site or extra abdominal recurrences can be performed by palliative chemotherapy. So this is the treatment. So this chart explains the management of loco-regional recurrent endometrial cancer. So previously, those who have received vaginal brachytherapy, this time we have to give them EBRT or external beam radiotherapy. Previously, there is no radiotherapy, then EBRT plus minus brachytherapy can be given. Patient who received a prior radiotherapy, then we can try complete debulking, and systemic therapy can also be done in last two cases, like hormonal therapy with medroxyprogesterone acetate, standard chemotherapy with carboplatin and paclitaxel 3 weekly for 6 cycles, and there is immune checkpoint inhibitor pembrolizumab lenvatinib which can be also tried as a second line management. Thank you.